Embryology of GIT. Let's begin by going back to a point very early on in development, just a few weeks after fertilization. The embryo looks something like this drawing on the left. There are two cavities, one is called an yolk sac and one is called the amniotic cavity. And where they meet, this is called the embryonic disc, and this is where all the action in the growth of human being takes place. This is where all the organs and structures that we know are going to come from. What happens early on in development is that this embryonic cavity folds in multiple directions, so it folds in four directions and wraps around the yolk sac. And after a few weeks, you then have something that looks like the drawing on the right side of the screen. You can see this blue line that was the interior of the amniotic cavity is now stretching all the way around the growing embryo. What you have in the middle of the screen is a white area which is used to be the yolk sac, and this is now a hollow tube, and that is going to grow into the digestive tract, that is also called as the digestive tube, and it comes from the yolk sac. This picture on the left shows a zoomed in view of embryonic disc. Remember, that's the interface between the amniotic cavity and the yolk sac. That's where all the action takes place and where all the organs we know in the adult are going to come from. And if you zoom in on the embryonic disc, you will see that it's made up of three layers. The middle layer shown in red is called the mesoderm. One on the outer layers is called the ectoderm, that's shown in pink. The other outer layer is called the endoderm, that's shown in brown. And as this early structure develops into the structure on the right side of the screen, you will see that once again there is a hollow tube that comes from the yolk sac shown here. That's going to develop into the digestive tract. And you can see in this picture on the right side that it's surrounded by brown, and I'll show you that to remind you that the surrounding structures of the GI tube come from the endoderm. So things like the lining of the GI tract in many of the abdominal organs all come from the endoderm, which wraps around this digestive tube which came from the yolk sac. Just outside of that endoderm, you can see red line. That red represents mesoderm, and that's where all the connective tissue and muscles surrounding abdominal structures in the GI tract are going to come from. So here's a summary slide just to make these points clear. The endoderm develops into GI tract. It forms the GI tract epithelium and the glands. Many organs bud off from this, including the liver, pancreas, and trachea. We'll talk about all of this in the module today. The mesoderm forms the surrounding structures like the stroma of the GI tract, connective tissues, muscles, peritoneum, and spleen. Spleen is a special organ in the abdomen because it comes from mesoderm. We'll talk about it later in this module. As the embryo continues to develop, it eventually will start to look like this. At this point, we have a long gut tube. This portion up here is going to form the mouth and the pharynx. These are the final pouches, and then the remaining length of the developing digestive tube can be split up into three sections. The first section is called the foregut, the next one is the midgut, and the last one is the hindgut. The three sections of the developing embryo Each one will eventually be supplied by the different branch of abdominal aorta. All the structures that derive from the foregut will be supplied by the celiac trunk that includes the esophagus and the stomach, which is budding out here, and other structures. The midgut will all be supplied by the SMA, that is the superior mesenteric artery, and the hindgut will all be supplied by the IMA, that is the inferior mesenteric artery. So this is a different portions of the GI tract and where they derive from in the developing embryo. So the foregut gives rise to everything supplied by the celiac trunk, and that's all the structures from the mouth to the angle of Vater. The midgut gives rise to everything supplied by the superior mesenteric artery or the SMA. This is everything from the angle of Vater to the transverse colon, and finally the hindgut gives rise to everything supplied by the inferior mesenteric artery that includes structures from the transverse colon to the rectum. Next, let's talk about the mesentery. When you look inside the abdominal cavity, you can find sheets of connective tissues called mesentery. It is made up of a double layer of peritoneal tissue and suspends the abdominal organs from cavity walls. Blood vessels also travel through the mesentery as they go from the aorta to the organs which they supply with blood. Organs that we call intraperitoneal are entirely enclosed and wrapped within the mesentery. Organs that we call retroperitoneal are covered by peritoneum only on their anterior wall and against the posterior abdominal wall. Here's a recreation of some of the structures in the abdomen to give you an idea of what I am talking about. The red line here represents the mesentery, and you can see that there is a loop of intestine, small intestine here, completely wrapped in mesentery. So that would be an intraperitoneal structure. Other structures in the back of the abdomen, like the aorta and the inferior vena cava, are not wrapped in mesentery. They are retroperitoneal structure. They have mesentery covering only on their anterior walls. As we talked about earlier in this module, connective tissue structures in the abdomen do not derive from endoderm, they come from mesoderm. So the entire mesentery comes from mesoderm, and that's easy to remember because it has the word knees in the name of the structure. And there are two types of mesentery that form. The first type is towards the back of the fetus. That's called dorsal mesentery. Dorsal means towards the back, and the second type is towards the front. That's called ventral, means towards the front. Most of the connective tissue structures in the abdomen come from the dorsal mesentery. The reason for this is because the gut moves away from the post your wall. The reason for this is because the gut moves away from the posterior wall in development, and the dorsal mesentery grows between the gut and the posterior wall, so that most of the structures are covered by this mesentery. To understand this better, imagine that we have the posterior wall of the fetus and we have the gut tube here. It is going to be covered in mesentery, and then it is going to migrate away from that posterior wall. As it does so, it will put that mesentery with it, and the result will be that this dorsal mesentery coming off the back of the fetus ends up covering more structures in the abdomen and being responsible for most of the mesentery if they are in the abdomen. Ventral mesentery, on the other hand, only exists in a couple of places. You can find it in the esophagus. You can also find it in the stomach. That's one of the most important places. We'll talk about that in the following module. And you can find it in the upper duodenum. It is derived from a structure called the septum transversum, one which is meant that it also comes from the mesoderm. What's important to know about the ventral area is that the liver grows into this, and thus two structures on either side of the liver come from ventral mesentery. The first one is the lesser omentum, and the second one is the falciform ligament. This is an image depicting the septum transversum, and remember, all the ventral mesentery comes from septum transversum. You can see that it's a sheet of tissue going across the liver to the stomach, and the liver is growing into it. This means that when the baby is fully formed, all that will remain of the septum transversum and the ventral mesentery will be this connection between the liver and the anterior abdominal wall, and that's called the falciform ligament, and the connection between the liver and the stomach, and that is called the lesser omentum. Here's another picture of the liver and the stomach. You can see the lesser omentum in this structure in here between the stomach and the liver. Not shown is the falciform ligament, which is on the outside of the liver that connects to the entire anterior abdominal wall. Both of these structures derive from ventral mesentery. The mesentery goes by different names depending upon which abdominal organ it is surrounding. So the mesentery also around the stomach is called the mesogastrium. The mesentery around duodenum is mesoduodenum, and around the colon is mesocolon. Hopefully you all get to go into the anatomy lab and open up the abdomen. When you do, you will see that there is the sheet of connective tissue and fatty tissue hanging off the stomach, and that is called the greater omentum, and the word omentum is a Latin word for apron, and the greater omentum hangs from the greater curvature of the stomach and covers the intestines. It is derived from mesogastrium and therefore derived from mesoderm tissue. There's also the lesser omentum, which we saw on the last slide, that is connection between the stomach and liver, and as I said before, it's hard easy to remember that the structure is formed from ventral mesentery. Now, let's talk about each of these three sections of the embryonic gut tube: the foregut, the midgut, and the hindgut. And I'll talk about how each sections develop and the important anomalies that you need to know about for step 1. We'll start by talking about the foregut. This is what forms the esophagus and the stomach, and the most important thing to know about the foregut is that the lung will bud off from the esophagus in the developing embryo. This budding off of the lung is called the respiratory diverticulum or the lung bud. Eventually, a structure called the tracheoesophageal septum will form, and it will divide the respiratory diverticulum or the lung bud from the esophagus. And then the fetus will go on to mature and develop a separate trachea and esophagus. If there is abnormal development of this tracheoesophageal septum, that leads to congenital pathology, and the most important pathology to know is the esophageal atresia. This is a closed esophagus, and this is what occurs when the septum deviates posteriorly. If we go back to this picture shown right here, is the lung budding off from the esophagus, and the septum needs to form between the lung and the esophagus to divide the two tubes into separate structure. If this septum deviates posteriorly, it will cut off the esophagus, and then the esophagus will end in a blind tube, and that's called esophageal atresia. There are three forms of esophageal atresia. The most common form is called the esophageal atresia, that's EA, with tracheoesophageal fistula. A tracheoesophageal fistula is a connection between the trachea, which is here in the lungs, and the esophagus, which is distal portion of the esophagus. The proximal portion of the esophagus has been cut off, that's why it is called esophageal atresia. Another form of esophageal atresia, which is less common, is called the pure esophageal atresia. This is where the esophagus ends in a blind tube and the more distal esophagus is not connected to the atresia at all. And then finally, there is a more rare atresia type where the esophagus and the trachea are both separate tubes, but they are connected by a fistula. When the fetus develops, the esophagus does not connect to the stomach, as we have just seen. This means the baby cannot swallow amniotic fluid. This means there will be an excess of amniotic fluid present in the mother, and this is called polyhydramnios. When these children are born, they will have drooling and choking and vomiting, and all of this is because relation of secretions is occurring in their mouth because they cannot swallow these secretions and pass them into their stomach and intestine. To try and control the excess secretions, a nasogastric tube is often passed into the stomach of the babies, We have symptoms like this, but in the case of esophageal atresia, you will find that you cannot pass the NG tube into the stomach, and that's because the esophagus ends in a blind pouch, and this is a characteristic finding of babies with esophageal atresia. If there is a fistula between the esophagus and the trachea, as we saw in some of the forms of esophageal atresia, the baby will develop gastric distension, and that's because air is passing from the trachea into the stomach, and you can see an excess of air in the stomach on a chest X-ray of these children. In addition, these babies will have reflux of stomach contents, and they will develop aspiration pneumonia, and this will lead to respiratory distress. The treatment of the esophageal atresia is a surgical repair, and prognosis is generally okay sometimes. There is residual dysmotility and swallowing problems in the esophagus, and these children often suffer from heartburn or gastroesophageal reflux disease as a result of damage that occurred to the esophagus. Next, let's talk about development of midgut, and there are two phenomena that occur in midgut development that you need to know about. The first one is called the herniation, and the second one is called rotation. Herniation is where the contents of the midgut normally exit the abdomen and then return. This is a normal part of development. Rotation is when the contents of the midgut rotator on the superior mesenteric artery. So we'll talk about both of these now, and we'll start with herniation. About the 6th week of development, the abdomen temporarily becomes too small, so the midgut herniates through the umbilical cord. This is called physiologic herniation, and you can see it on fetal ultrasound, and the hernia will reduce and contents will go back into the abdomen by about the 12th week. It's the midgut does not return to the abdomen, the baby will be born with omphalocele. This is a persistence of normal herniation process. Intestines will be outside of the body covered by a membrane. When the membrane only contains intestines, it's called simple omphalocele. Normally, the liver does not herniate. However, if the lateral embryonic folds fail to form, then the liver can sometimes be in the omphalocele. This is a more complex defect. This is called liver-containing omphalocele. The key features to know about this, especially for your exams, are the intestines and the midgut are covered by peritoneum that distinguishes from gastricus, which we'll talk about in a minute, and also that it is through the umbilical cord. This feature also distinguishes omphalocele from gastricus. Babies born with omphalocele usually have normal GI function. Unfortunately, they often have an associated genetic defect, trisomy 21 or Down syndrome, or trisomy 18, that is the Edwards syndrome, or trisomy 13. There are many other associated congenital anomalies that babies with omphalocele have. This includes congenital heart defects, up to half being born on the children. They'll have the congenital heart defect, also oral facial clefts and neural tube defects. A related congenital anomaly due to omphalocele is called gastricus. Gastricus is the extrusion of the bowel through the abdominal wall. The exact mechanism is not clear. It probably involves incomplete closure of the abdominal wall. Importantly, the bowel will herniate through a para-umbilical defect. Sorry, it won't be through the umbilical cord. It is usually on the right side of the umbilical cord, and the intestines are outside of the abdomen and are not covered in peritoneum. And this distinguishes gastrocus from omphalocele. The problem with gastrocus is that the bowel is usually damaged when it comes outside of the abdomen, so these children often have a poor GI function. Gastricus is often associated with bowel atresia and stenosis. The good news is about gastricus is that it has a few associated defects, so if GI function is restored, there is usually a good prognosis and is rarely associated with Down syndrome or other congenital conditions. So here's a slide comparing the two types of abdominal defects where you find abdominal contents outside of the baby. First one is omphalocele, in which you can see that it is an umbilical defect. The bowel is covered by membranes. There are many associated conditions but usually normal GI function. Gastritis, on the other hand, is a para-umbilical defect. The intestines will not be covered by membrane. There are a few associated congenital conditions, but there is often poor GI function when the defect is resolved. And the treatment for both of these problems is surgical reduction and closure. Now, let's talk about the rotation that occurs during mid-gut development during physiologic herniation. When the bowel is outside of the body, the bowel rotates, it twists around the superior mesenteric artery. This process continues after the bowel returns to the abdomen. It results in the normal positioning of the small bowel and the colon. Importantly, it results in the ending up of the right lower quadrant where it's normally found. When this process does not occur normally, it leads to malrotation of the gut, and this can cause a number of problems. First of all, it can cause a bowel obstruction. The way this often happens is the cecum winds up in the mid-upper abdomen. When it winds up here, it stretches the peritoneum and creates bands of perineal tissue fibers, bands called they create the bands of perineal tissue. These bands cross the duodenum and they often lead to duodenal obstruction. Malrotation can also occur when the small bowel twists around the superior mesenteric artery. This leads to vascular compromise in ischemia and ultimately leads to bowel obstruction. Babies who develop this problem develop vomiting and sepsis from bowel necrosis. They develop abdominal distension and blood can be found in stool, and the treatment is urgent surgery. And then finally, malrotation can also lead to what's known as the left-sided colon, which is an anatomic variant. Now, let's talk about the vitelline duct pathology. Recall before that, I told you that vitelline duct is a remnant of yolk sac, so you should know that in early development, the midgut retains its connection to the yolk sac. The hindgut and the foregut become enclosed tubes, but the midgut stays connected to the yolk sac by week 5. The connection with the yolk sac starts to narrow, and this narrowing is called vitelline duct. That's sometimes also called a yolk stalk or the old mesenteric duct. And normally it will disappear by about week 9. If it persists for any reason, you can develop a couple of different congenital anomalies. The most common and the most important is diverticulum. But you can also develop cyst and polyp. The most important vitelline duct pathology is Meckel's diverticulum. This is the most common congenital GI abnormality. It is a persistent remnant of vitelline duct, and when you have a diverticulum, you have a diverticulum Meckel's or an outpouching or a bulge of small bowel that occurs at the ileum. This is easy to understand if you remember that the entire gut tube is formed from yolk sac and is the vitelline duct. If the vitelline duct persists and you are going to have a persistent bit of intestines. The yolk sac forms intestine so that the vitelline duct will also look like the intestine. It will just be a little bulging outward, usually at the level of ileum. It's very important that you understand that a Meckel's diverticulum is what's known as a true diverticulum. It contains all layers of the intestine, the mucosa, the submucosa, and the muscular layer. Most diverticulum only contain the mucosa and submucosa. Usually there is a defect or hole in the muscular layer, and the mucosa and the submucosa protrude through the hole to form a diverticulum. To understand this, imagine that you have a mucosa and then a submucosa and then finally a muscular layer of intestinal wall. Most diverticulum result from a hole in the muscular layer. When this hole occurs, these two layers herniate out through the hole, causing a diverticulum. This diverticulum only contains two layers of the wall, the mucosa and the submucosa. It does not contain the three. This is also called a false diverticulum. A true diverticulum, on the other hand, Like a Meckel's diverticulum involves all three layers, and a Meckel's diverticulum, you have muscular layer going like this in the mucosa, submucosa, and the mucosa, so that all the three layers are part of the bulb or outputting budding. That's relatively unusual. It's much more common for diverticulum, like the one about in the older people in the colon, to occur from a breakdown of muscular layer and thus to become a false diverticulum. It's also high yield to know that Meckel's diverticulum often contains stomach tissue. This is called ectopic gastric tissue. Its origin is unclear, but as we'll see in a minute, this can be used for diagnosis. Sometimes these diverticulum also contain pancreatic tissue as well. Most people who have Meckel's diverticulum do not know it and they have no symptoms. When these are symptomatic, they can present at any age but half percent before age 10, and many people think of a Meckel's diverticulum as a childhood disorder. It's often discovered incidentally when someone has imaging with the abdomen for some reason, or if they have abdominal surgery, for example, to remove an inflamed appendix. Sometimes diverticulum will be noticed on inspection. The ectopic gastric tissue present in the diverticulum may secrete acid, and this can cause ulceration and belly pain, and sometimes bleeding, and potentially these diverticulum are the cause of obstruction or diverticulitis. There is something called the rule of twos that many people remember to recall the features of Meckel's diverticulum. 2% of the population has Meckel's diverticulum. The male to female ratio is 2:2. They usually occur within 2 feet of ileocecal wall in the ileum, and they are usually 2 inches in size. There are a couple of ways to make a diagnosis of Meckel's diverticulum, but one of them is called technetium scan. The patient is administered a radio-labeled substance, capsule endoscopy. In this, the patient swallows a capsule that takes pictures as it moves through the intestines, and sometimes in those images you can see the diverticulum, and the treatment for symptomatic Meckel's diverticulum is surgery. There are some other rare vitelline duct anomalies. Some of them are often discovered accidentally when abdominal surgery is done for another reason. What happens in a cyst is that the vitelline duct largely obliterates and is replaced by fibrous tissue, but there will be a small opening or cyst that is present between the bands of fibrous tissue. Sometimes you can get a sinus. It will occur behind the umbilicus where the vitelline duct normally connects. In this situation, you have the abdominal wall and you have the small intestine. You will then have fibrous tissue connected to a cavity behind the umbilicus like this. And then finally, rarely people can be born with a persistent vitelline duct. In this case, you will get intestinal discharge from the umbilicus. Now, let's talk about atresia and stenosis of the abdomen. Atresia means a closed or absent opening, so a bowel that has atresia will end in a blind pouch. Stenosis means narrowing of bowel, and this will lead to obstruction, and atresia and stenosis can develop anywhere in the GI tract. The most common site, duodenal atresia. Duodenal atresia probably occurs due to failure of recanalization. In early development, it turns out that duodenum normally becomes included. This is because of proliferation of the epithelium, and endothelium begins to proliferate on both sides, and it proliferates so much that it obstructs the duodenum. Then there's a process by which it is recanalized and opened back, and the result is that when the baby is born, you have normal duodenum. In this process, if this process fails to occur, then you have a failure of recanalization, and that leads to obstruction in duodenum. To high-yield things to know about duodenal atresia is that it is associated with Down syndrome, and that can lead to what's known as double bubble sign on imaging. This occurs when there is distension of the duodenal stump and the stomach with a tight pylorus in the middle. Normally, the stomach leads into the pylorus and then goes into the duodenum. However, if duodenum ends in a blind pouch from a trachea, then the duodenum will become massively distended. As a result, on imaging, you will see a swelling at the stomach, a swelling in duodenum, and a tight narrowing. Here at the pylorus. That's called the double bubble sign. As I told you, for the duodenum is the most common location for atresia, but it can rarely occur in jejunum, the ileum, and the colon also. When it occurs in these locations, the mechanism is believed to be vascular disruption, that is, ischemic necrosis of intestines. Necrotic tissue unresolved, leaving behind ends of the bowel. This also looks like the apple peel, so it's called the apple peel atresia. Moving on, let's talk about pyloric stenosis. The pylorus is the connection between the stomach and the duodenum. It's the site where stomach contents exits the stomach and enter the small intestine. If there is hypertrophy of the pylorus, this leads to pyloric stenosis. This will cause intestinal obstruction. Classically, these babies present with projectile non-villous vomiting. So non-villous means clear or yellow vomiting is the bilious vomiting. The bilious vomiting is usually dark green. The reason it is not bilious is because the obstruction occurs prior to the entry of bile into the small intestine. Therefore, the bile cannot get back into the stomach and it's not the part of vomitus. Another key finding of pyloric stenosis is a palpable mass that feels like an. Moving on to the last topic for this module, that is the embryology of spleen. Spleen arises from the mesoderm. Its blood supply is the salient trunk just like the stomach. So it gets the blood supply of a structure from the endoderm in the foregut. But in fact, it comes from the mesoderm. In a normal development, stomach rotates and spleen moves over to the left side and it retains a connection to the stomach called the gastrosplenic ligament. It's also called as the gastrosplenic ligament or the gastrolineal ligament, and this carries the short gastric arteries and left gastroepiploic vessels. This is the spleen shown here in the picture. The splenic artery, the salient trunk, the short gastric arteries and many other vessels can be seen in this picture. That concludes our module on GI embryology. Thank you and have a nice day.